Assalamu alaikum and a huge welcome to everyone. Let's just jump right into it. Today, we're bringing you a brand new explainer that dives deep into one of the most physically demanding, absolute highest stakes moments of human existence, literally taking that very first breath as a newborn baby. We are going to break down the complex biological mechanics behind neonatal respiratory diseases, pulling directly from top medical sources. I am super excited to guide you through this, so get ready to look at the incredible science of the newborn breath like never before.
Okay, so here's our roadmap for this explainer. It's a complex clinical topic for sure, but we've broken it all down into 5 easy-to-digest parts. We'll start off with fetal lung development, move on to that crucial first breath, then explore respiratory disturbances, touch on other common pathologies, and finally look at how modern diagnostics and treatment step in to save the day. All right, part 1, fetal lung development. Let's look at how this whole journey actually kicks off. To really understand why a newborn might struggle to breathe, we actually have to rewind the clock back into the womb. A baby's ability to breathe at birth doesn't just happen, it's an intricate process that starts way, way early. At just 4 weeks of gestation, you get these tiny bronchial buds appearing. Fast forward to 18 or 20 weeks, and the alveoli and tiny blood vessels are starting to form. But the real magic, the absolute turning point, happens between weeks 20 and 24. That's when specialized cells called type 2 alveolocytes show up and start producing something incredibly essential. By weeks 26 to 28, the alveolar capillary barrier is finally established. So this 20 to 28 week window, it's literally the biological threshold that decides if a preemie has the anatomical hardware to survive outside the womb. And that brings us to the absolute star of the show. We're talking about our hero molecule, surfactant. Produced by those type 2 alveolocytes we just talked about, surfactant is this highly precise biological cocktail made up of 90% lipids, mostly phosphatidylcholine, and 10% vital proteins, specifically proteins A, B, C, and D. So why is this so critical? Well, imagine trying to blow up a wet, sticky balloon. Without this exact molecular recipe coating the inside of the baby's lungs, the alveoli will just completely collapse every single time the baby exhales. Without surfactant, taking continuous breaths is practically biologically impossible. Moving right along to part 2, the crucial first breath. For 9 whole months, a baby's lungs are just chilling, filled with amniotic fluid. Then suddenly, in a matter of seconds during birth, those fluid-filled lungs have to drain and immediately fill with air. To make that happen, a newborn has to generate minus 70 centimeters of water in negative pleural pressure entirely through their own muscle strength. Minus 70! Just wrap your head around that number for a second. Pulling that first 70 milliliter breath of air into heavy, fluid-coated lungs requires a staggering, massive amount of mechanical effort compared to how you and I breathe right now. And honestly, the deck is kind of stacked against them right from the start. Newborns have these huge natural physical limitations. Their airways are super narrow, their ribs sit horizontally instead of being angled for optimal expansion, their intercostal muscles are incredibly weak, and the respiratory center in their brain is still totally immature. Put all that together, and newborns are at a massive physiological disadvantage the moment they arrive. It's an uphill battle just to keep the air flowing. So, what happens when things don't go according to plan? Let's get into part 3, respiratory disturbances. When a baby's respiratory system can't adapt, this is where doctors have to step in and play clinical detective. They rely on 2 major diagnostic scales to figure out exactly how badly the baby is struggling. And they pick the scale based on when the baby was born. They'll use the Silverman scale for premature babies and the Downs scale for full-term babies. Both of these look at really specific red flags: chest retraction, cyanosis, which is that dangerous bluish tint to the skin, expiratory grunting, and overall breathing rate. By checking these boxes, doctors systematically score the respiratory failure from 0 to 10. It instantly tells them how fast they need to move. Now, the most famous, or maybe infamous, of these disturbances is hyaline membrane disease, which you probably know as respiratory distress syndrome, or RDS. The main villain here is exactly what you might guess based on what we talked about earlier: a critical lack of surfactant. Maybe it's missing because the baby was born too early to make it, or maybe conditions like hypoxia or acidosis shut down its production. But the bottom line is, without surfactant, the lungs just give up, leading to extensive alveolar collapse and serious tissue damage. But here's the really tricky part about RDS. It is incredibly deceptive in how it progresses. It happens in 3 distinct stages. Stage 1 is what doctors call the bright interval.
For the first 4 to 6 hours, the baby might actually look totally fine as they burn through whatever tiny reserve of premature surfactant they have. But then we hit stage 2, the manifest phase, which lasts about 48 hours. This is where things crash fast. Breathing rockets to over 72 breaths per minute, deep cyanosis sets in, and you hear this awful expiratory grunting as they fight to keep their airways open. Stage 3, between days 3 and 10, is the ultimate turning point. It either leads to a slow recovery, or tragically, it becomes terminal and ends in multi-organ failure. All right, part 4. Let's zoom out a bit and look at a few other major hurdles in the neonatal ward. Because surfactant deficiency definitely isn't the only bad guy here. Let's talk about meconium aspiration syndrome, or MAS. This happens when a baby accidentally inhales their own first stool, called meconium, right into their lungs. And how it looks clinically totally depends on when the stress happened. If the fetus was dealing with chronic hypoxia, slowly losing oxygen over time in the womb, you'll see severe distress and asphyxia at the exact second they are born. But if the hypoxia was acute, like a sudden drop in oxygen during delivery, you might actually get another deceptive bright period. Then, boom, they crash as those tiny toxic meconium particles migrate deeper into the lungs, triggering massive inflammation.
Then we have transient tachypnea, which you'll often hear called wet lung. This is basically a delayed clearance of fetal lung fluid. And it's super fascinating when you think about the primary risk factor here, planned C-sections. Why is that? Well, when a baby totally skips the physical stress of being squeezed through the birth canal, they miss out on a massive natural surge of catecholamines. Those stress hormones actually tell the lungs, hey, stop secreting fluid and start absorbing it. Without that chemical signal, the baby arrives with wet lungs, breathing over 60 times a minute, puffing out a barrel-shaped chest, and usually needing oxygen support for 1 to 4 days until that fluid finally clears.
Which brings us to a really tragic irony in neonatology: bronchopulmonary dysplasia, or BPD. The risk equation for BPD is basically oxygen plus mechanical pressure plus time, all acting on immature lungs. The harsh reality here is that the exact same tools used to save a premature baby's life, we're talking high-concentration oxygen therapy and the aggressive force of mechanical ventilators, they are actually toxic over a long period. The free radicals from the oxygen and the physical trauma from the pressure literally cause chronic, fibrotic scarring in that incredibly delicate lung tissue. Let's bring it home with part 5, diagnostics and treatment, how modern medicine actually fights back against all this. The good news is, we don't just leave these babies to fight alone. Before a baby even takes a breath, doctors have some pretty clever ways to check lung maturity using amniotic fluid. One of the coolest is the Clemens foam test. It's basically a rapid-fire bedside chemistry experiment. They take exactly 0.5 milliliters of amniotic fluid, add 0.5 milliliters of 95% ethyl alcohol, and then just vigorously shake the tube for 15 seconds, wait 15 minutes, and then check for a stable ring of bubbles on top. If those bubbles hold their ground, it means there are enough surfactant lipids in there to stabilize the foam. Translation: that baby's lungs are very likely ready for the outside air. For something a bit more mathematically precise, the lab can check the lecithin to sphingomyelin ratio, the LS ratio, in the amniotic fluid prenatally. This is a real game changer because it lets doctors predict respiratory distress almost down to a science. If the ratio of lecithin, which is a huge part of surfactant, to sphingomyelin is greater than 3 to 1, the risk of RDS is incredibly rare. But as that ratio drops between 1 and 2, the risk spikes to 50%. And if that ratio falls below 1, the medical team is staring down a 75% probability of severe respiratory failure at birth.
So what's the game plan if they know a premature birth is happening? First, they call in the therapeutic cavalry prenatally. They'll give steroids, specifically dexamethasone, to the mother. This kicks the baby's lung surfactant production into overdrive while they're still in the womb. But if the baby is born and is still struggling, neonatologists will physically step in. They will literally drop exogenous animal-derived surfactant, stuff like CuroSurf or Infisurf, straight into the baby's lungs through a tiny tube. It physically coats the alveoli from the inside, while machines like CPAP or a ventilator provide gentle support. Okay, pause right here because this is absolutely crucial if you're studying this field today. Postnatal glucocorticoids, meaning giving steroids like dexamethasone directly to the baby after birth, are no longer recommended. I know, in theory, fighting inflammation sounds like a smart move. Actually, scratch that old protocol, because the severe systemic side effects completely outweigh the benefits. Giving postnatal steroids directly to the newborn causes terrible hyperglycemia, it increases the risk of dangerous gastrointestinal bleeding, and it totally tanks the baby's already fragile immune system. Modern medicine says no way. We rely on surfactant replacement and gentle ventilation instead.
So that leaves us with a really huge question as we wrap up. Can medicine ever fully conquer respiratory distress? I mean, we've gone from simply watching premature babies succumb to lung failure to literally synthesizing the biology of a breath inside a syringe. It's mind-blowing. But with lingering threats like lung fibrosis still out there, the battle is absolutely far from over. Next time you take a deep breath, just think about the monumental physical effort your very first one required and the brilliant science happening every day that ensures millions of babies don't have to fight for theirs alone. Thanks for hanging out with me for this explainer. Stay curious, and we'll catch you next time.